for your exam, I don't ask any question about the taxonomy, but we should know that we are classified as the Sarcomasticophora in the phylum Sarcomasticophora and subphylum Sarcodia. And in the class of Globozoa, we have Globozoa in the family of Entomobidae. Here we have Entomoba, Entolymos nana, and Iodomoba or Iodomoba buchlei. In the genus of Entomoba, we have different species. Entomoba histolytica, dispar, parsimony, coli, gingivalis, and so on. The most important one is Entomoba histolytica. As you see, histolytica, it can lyse lytica, histo. It can lyse the histo, the tissue of our body, so it can be pathogen. Also, we have Entomoba dispar. It is very similar to histolytica. The morphology are the same, but we have so many biochemistry and molecular methods that we can distinguish these two protozoa. And also parsimony is a smaller size. They are non-pathogen. Coli is in the colon. It is non-pathogen. Entoma gingivalis is vocal cavity. It is also non-pathogen. But you should distinguish these under the microscope. For your practical class, you just see histolytica and coli. About the Entomoba histolytica that induce the disease, the disease name is amebiasis. And the geographical distribution is mostly in tropical and subtropical areas. And geographical distribution, about the histolytica is mostly tropical and subtropical, and between 350 to 400 of the people are at risk and can be infected, but just 10% of the people have manifestation or have symptoms. So the infectivity is high, but the symptoms most of the time, 90% it is asymptomatic, without any symptoms. Just in 10% we have the specific symptoms such as dysentery. About the distribution, it is just specific for human. We don't have any animal reservoir, just specific for human. It is very important for the prevention. The disease that is specific for human, we just care about the hygiene. We can block the translation and we can reduce the disease in the society. It is fecal oral because it is spread in the stool. They have the cyst form, which is infective. They have a cyst form, which is infective. It is passed through the stool, and after that can infect our food, our water, and after that the other human. So it is, we don't have any animal reservoir, and it is fecal oral. We should ingest it, we should eat it or drink it with our mouth. Because of that we say oral fecal or oral anal. It is colonized in large intestine, not in a small intestine, just colonized in large small intestine, and produce the lesion, the ulcer, dysentery, and amebiasis. I don't ask question or your quiz not about the estimation or the number of days, or just I just want you that you know about the importance of the disease. But for your exam, I told you that which slide is much more important, and focus on that. Because the human are the whole and the core of the disease, so in industrial country or the society that the hygiene is very low, because it is oral fecal, the hygiene is very important, and it can spread between the society, in the crowded society or in the low hygiene, mostly in developing countries. And also about the historical, it is endemic in some countries. For example, in Bangladesh, in Mexico City, in South of America, we have some places that we have a high prevalence of the historical. So, as a physician, you should know that the endemicity of the disease, which places, if you live in country, which region of your country, which country in the world have different disease, because we have so many travel and also, for example, immigrants from these places, if they have, for example, dysentery, diarrhea, but in 6 months before they travel to endemic region, this is the history that helps us to diagnose or suspect to historical. If the patient comes to you, you should ask the patient that during 6 months ago, for example, have you ever traveled to immigrants to endemic region, or do you come from these places? So you should know the places that endemic to the disease, not for historical. For all of the disease, you should know the spread of the disease. So the traveler, the immigrant, also can be in the high risk, and also a homosexual, because it is oral fecal or oral anal. Homosexuals, because of their behavior, they are sensitive to all of the parasites, virus, all of the agents that colonize in the large intestine or colon. They have two forms. One of them is the active form, which is with the trophozoite, and also they have the non-active form, the cyst form. The trophozoite has the nucleus, the karyosome or endosome, which is centric in the middle of the nucleus. They have cytoplasm, and also they have pseudopodia. And because of these pseudopodia, they can phagocyte, they can attach to our body, and they can be motile. They produce cyst form, which is infective. The cyst form first have one. After that, they do mitosis. They produce 2 cysts, and finally 4 cysts. They have 2 forms of the trophozoites. One of them is non-invasive, which is, we thought that minotaur, and one of them is invasive form, which is hematophage or magna. We said it hematophage because it can phagocyte RBC, red blood cells, that enrich with hemoglobin. So because of that, we said hematophage. in your exam, your practical class, you see this hematophage, and maybe in your exam, you see it under the microscope. So pay attention that for tomorrow, for your class, please told your classmates that for tomorrow, all of them should be in a class. We have 3 sessions, and the slides is very difficult, and most of the students, it's very hard for them to distinguish.
Practical tomorrow? Practical?
For your practical class, when you're in your theoretical, nobody is coming. I told you that. Do you have a Telegram or WhatsApp?
WhatsApp.
On behalf of me, please write that. They must be at the class for tomorrow because it is very practical, it is very important, and maybe they fail from the class. Because in Tehran, most of the times we have the 9 to 10 score. They fail. We have some students with 80 or 90, but most of them are, unfortunately, they don't be at the class. And because you are in Kish, maybe we can't change your number, your score. Okay. The trophozoites, it has a non-invasive form that we said Minota, and also invasive the hematophage form. You should memorize that specifically for your practical class. They have a ectoplasm. The outside, this is that's hyalinic. It is ectoplasm, and the endoplasm, they have some walkway, they have some granule. But pay attention to the nucleus and the chromosome, and also the peripheral chromatin. The chromatin inside the nucleus that attached to the nucleus ball is said peripheral chromatin. In histological, the peripheral chromatin is very fine and very tiny. In hematophage, in the cytoplasm, you see RBC, which is red. They produce also the system hematophage. This is the sample of the patient with dysentery. Dysentery is diarrhea full of RBC. This is white BC. These are RBC, and this is entomopathy histological, the hematophage 4. These are RBC that it can be ingested or with trophocytes. And this is the nucleus with chromosome and the peripheral chromatin. Also, they have the cis form. The cis form have 1, 2, 4 nucleus. In the immature cis, we have the glycogenic walkway and also the chromatoidal bar. The glycogenic walkway has enriched glycogen, the source of the carbohydrates, and also the chromatoidal bar have RNA, ribonucleic acid. Because they have the cis wall, they don't fit on the nutrients of the outside. They just fit on the walkway and the glycogenic walkway that inside the cyst. They use it, they multiply, do mitosis, produce 2, and after that again produce 4 nucleus. This is the infected stage that pass through the stool and can infect our vegetable, our water, and the other person can infected with these four nucleus cysts or mature cysts. Why do you take video from the class? So we have the infective stage and the trophozoite. How they transmit? It can infect it directly. For example, person to person. Some individual, for example, infected, go to WC without washing their hands. Their hands can be infected with the stool that infects with the cyst. And after that, for example, touch your, for example, food or anything, especially the person that work with the foods or handling the foods, making the sandwich. These are very important. Or, for example, touch the common tools that you have in the, for example, what you say, dormitory. Yes? Can infect. About every, not parasites, all of the viral, bacterial, fungal, or of the protozoa that shed from the stool, the hygiene is very important. That and person to person, it can be infected from person to, it can be spread from person to person. And also about the homosexual, I told you, it can be infected through the oral anal and also food or drink that's contaminated with the infective stage. And previously, nowadays we don't use it. Previously, the human feces or human stool was used for as a fertilizer. Nowadays, just they use animal stool for the fertilizers. But previously, they used human fertilizer, human stool, and because of that, so many infective agents that in the stool of the human can infect the vegetables, the water. Because of not using human stool as a fertilizer, the prevalence of the human agent, human parasites or anything that infects from the human stool is reduced. And also the contamination of the food stuff by flies, cockroach. You know that these are the mechanical vector. They can put on, they go, for example, through the stool, and all of their body, their wing, can infect it with cyst or any microbial agent, and they go to our food and can infect our food with their wing or their body. On the whole, about the cycle, with person to person, or for example, we eat or drink the food that's contaminated with the mature cyst. The mature cyst, when we eat that, it goes to our stomach, and after that, in the small intestine, the cyst digested. You know that in the small intestine we have so many enzymes, pepsin, trypsin, bile, salt, all of them help that the cyst was ingested, and the trophozoite with 4 nucleus comes out from the cyst wall. This is the cyst wall. It is produced from the chitin. It is produced from the chitin and cellulose, and because of that, the cyst is very resistant. For example, in the refrigerator, they can be alive for 1 month. They can be alive for 1 month. The trophozoites come out from the cyst, and after that, the cytoplasts also multiply, and the trophozoites come out. The trophozoites go to colon or large intestine. In the large intestine, they multiply. So in the small intestine, just the cyst rupture, or we say existation happen. So existation or digestion of the cyst is happening in the small intestine, but after that, the protozoa come to the colon and they colonize in the large intestine. So the main place that they colonize, they multiply, or can be produce the symptoms is large intestine. The protozoa here can most of the times the best place for them is the beginning of the large intestine that we taught second. But they can multiply or infect all of the large intestine. But here the stool is watery, full of the nutrient, so it is the place is better for the multiply or replication. So they are mostly here and can attach and produce the lesion. So when we eat the mature cyst and the histological come to our large intestine, 2 scenarios happen. In some people, just histological multiply in the large intestine and eat the bacteria and the nutrients in the large intestine and don't invade to our epithelial cell, don't produce any disease, and they gradually then go to the end of the large intestine. They produce the cyst, and the cyst come out from the colon and spread in the stool. In these patients, they don't have any specific symptoms. We said they are asymptomatic. These individuals are carrier or cyst passer because they pass the cyst from the stool, and this cyst, for example, can infect other person, can spread through the society, or if the hygiene is low, they can, for example, infect our water. And also, for example, if the person infects have, for example, the cyst form, we should recognize them, we should diagnose them, we should treat them, because this is the source of the infection. Because we don't have any animal reservoir, the human can be a reservoir and can have this histological spread disease in the society. So we should recognize and diagnose them and treat them. This is the source of the infection. In some people, when histological come to a large intestine, they can invade, they can attach to the epithelial cell and produce some ulcer, some lesion, digest our RBC, our epithelial cell. And we have here the hematophage that in previous slide I showed you. They can digest the RBC and produce intestinal amebiasis. And sometimes the worst things happen. They can go through the mesenteric vessel, go through bloodstream, and outside of the intestinal tract, they can go to liver, lung, brain, and produce extraintestinal amoebiasis. So histolytica in some people can be asymptomatic, in some people they produce intestinal amoebiasis, sometimes they produce extraintestinal amoebiasis. So the range of the symptoms, the range of the disease is very wide. Why this happens? Why histolytica in some people don't have any symptoms, but in some people that even they spread to the liver and produce the disease. Do you have any idea?
Repeat your question. Repeat your question.
Why the symptoms in the histolytica is very wide. For example, in some people it don't have any, we don't have any symptoms, but in some people it can have produce extra or intestinal amoebiasis or spread, for example, through the liver. Why this happen? For example, some people just be a cis-passer or carrier. In some people we have extraintestinal. Why we have this variety of the
intensity of infection? Because of intensity?
No, I asked you why we have so many intensities, very 0 to 100%. Why we have this variety of the intensity?
Like someone is like when he takes some it is like dirty a lot, so it has a lot of cysts. So it's
in all of the microbial agents or in infectious disease, we have a variety of the disease. For example, in corona, in COVID-19, some of people that infected don't have any symptoms. Some of them hospitalized or dead.
Because of immune response?
One of them is immune response, the other
age difference?
Age difference, maybe.
Because
when the patients come to you, you should pay attention to the background of the patient. For example, the immune system is very important. As we see in the corona, we have, for example, in the same place, but we have the source of infection is same, the number of virus that we, for example, come to our body is the same, but the symptoms that we have in different person are different. Because of what? The genetic, because of the immunity, because of the virulence of the COVID. Yes? For example, in COVID-19, when it's happened, the virulence of the COVID or the virus is very high. But gradually, in the next year, it's very, because they multiply, they produce some subcolon, as you remember, and the pathogenicity of the COVID-19 is reducing gradually in 2 or 3 years, and after that, the symptoms nowadays, now we have COVID-19. Maybe we infected with that, but the symptoms is very low because the virulence factor of the virus is lower than the next generation of these virus. So in all of the microbial disease, in all of the infectious disease, we have the microbial agent and the host. Both of them is very important. And all of them can affect on the intensity of the symptoms. For example, if the host have immunodeficiency or HIV positive or some deficiency in immune system, they are susceptible to all of the disease, not histological, to all of the disease. So we have some things that we say pathogenicity or pathogenesis factor. in all the infectious disease, you should pay attention to pathogenesis factor. You should know that as the physician, as a doctor, for your patient in the future, you should pay attention to this item because the treatment may be different. You should know that the patient that comes to you, what is his or her background. If they have an immunodeficiency, they are susceptible to, for example, some opportunistic infection. That's normal people. They don't have any susceptibility, they are resistant, they don't have any symptoms. In the category, some infectious diseases are more prevalent, for example, immunodeficiency. So you should know the background of your patient. You are not you are different from the biology students. You should change your mind. You should pay attention to all the details and see everything from the whole. Okay, about the pathogenesis factor, we have the parasite factor. We have some strain that's more virulent, and also we have host factor. First of all, we speak about the parasite factor. Some strain of histolytica. So histolytica also likes other pathogenic, pathogenic factor or like viral, fungal, all of them. All the microbial agents have different species, different column, different virulent. In histolytica also we have it. We have some strain of histolytica. This is genus of histolytica. This is a species of histolytica, but they have some virulent, they have some strain that they divided based on their genetic. With the molecular process, for example, with PCR, we can recognize them. For example, COVID-19, because they have point mutation. For example, we have first column of, for example, bacteria, virus. Because of they multiply, they produce different generation. Okay. So gradually, because of the point mutation, we have different strain, and some of them may be more virulent, and some of them maybe the pathogenicity is reducing. So because of that, we have in every microbial agent, we have different strain. Also, as the same as others, histolytica also have some strains that the virulence, the pathogenicity is much more higher than other strain. The virulent strain have some character. For example, they can phagocyte RBC very simple, very rapidly. They can produce abscesses in the liver or in tissue. They produce lesion or ulcer. They can simply attach to the epithelial cell. They can attach to the epithelial cell, and after that produce the disease or lesion. They can phagocyte our RBC, our epithelial cell. Also, they have so many enzymes, and because of these enzymes, they can produce immune response. They can produce inflammation and acute inflammation, and sometimes because of that, they can produce diarrhea in the, for example, intestinal tract. About the host factor, the susceptibility of host is very important. For example, nutritional state is important. Protein deficiency can reduce our immune system. And iron deficiency also. So protein deficiency, because it's reduced the immune system. If we infected with the histolytica, and also we have protein deficiency, our symptoms are much more higher than normal people. Or if we have iron deficiency, because it needs iron, it needs RBC. For example, histological is very dependent on iron. Because of that, they phagocyte RBC. If enough iron in the lumen of the colon, they use this iron, and the symptoms is lower. So if the patient have iron deficiency, because they don't have enough iron in the lumen, they have to attach to our epithelial cell and digest our intestinal tract and phagocyte this RBC and feed and use the iron. So in these people, the symptoms is much more higher, and the symptoms is more severe. And also high cholesterol. When the cholesterol or the fatty acid in the lumen is higher, the histological is multiplied much more. The number of histological is increasing. They attach, and the more number of the parasites, much more, they produce much more symptoms, because the number of parasites is higher. They digest our epithelial and our RBC and produce the disease. The other criteria that in the host is very important is the immune system. Immunodeficiency, for example, deficiency in secretory IgA, all of the mucosal cavity, for example, buccal cavity, the small intestine, large intestine, all of them cover with secretory IgA. These IgA, these antibodies, they cover our intestinal tract or all of the mucosal surface, and they inhibit the attachment of the microbial agent. We have a very strong immune system that cover our mucosal, our digestive, our lung, for example, bronch, vagina, all of them. We have so many secretory IgA that inhibit attachment of the microbial agent. In some patients, they deficiency in these IgA, so they are more sensitive to any microbial agent like histological. Also, you know that AIDS or HIV is the virus that infected lymphocytes in the person, and so they are immune deficiency, and they are sensitive to most microbial agents. So if these patients infected with histological, the symptoms are more severe and intensified. And also alcoholism, homosexual are more susceptible. In homosexual, because they are infected with microbial agents, the number of parasites is much more higher, than the symptoms is more than other people. And also in alcoholism, they are more susceptible to extraintestinal amoebiasis or liver abscesses. The other things is microbiota. The normal flora of the bacteria or microbiota in the large intestine, we said microbiota. They are very important in pathogenicity of histological. Histological can use these bacteria in the intestinal tract, can feed on the bacteria. Also, these bacteria in this large intestine produce, they use the oxygen, and they help to reduce the oxygen pressure and produce the microaerobic environment in the large intestine. They adjust the pH of the colon. So the bacteria in the colon is very important for these parasites. They can adjust the pH, the pressure of the oxygen, produce the microRFE, and also the histology part can use these bacteria as a food. So it is very important for them. And because of them, some physicians, besides the anti-amoebic drug, they use antibiotic. These antibiotics help to reduce the number of the bacteria, and the anti-amoebic also help to reduce the number of the amoeba. So these bacteria so help to produce and multiply the number of the amoeba much more than normal. About the clinical symptoms, I told you that we have some cyst passive and that they don't have any symptoms. We told them asymptomatic. The other situation, we have symptomatic infection. In some people we have intestinal, in some people we have extraintestinal, and sometimes both of them may be happen. In intestinal amoebiasis, the hallmark is dysentery. The hallmark of the histological is dysentery, but sometimes they just have colitis, inflammation of the large intestine, and sometimes we have diarrhea, but we don't have any RBC in the stool. But in the severe form, we have dysentery. In the extraintestinal amoebiasis, mostly the liver is infected, and here we have liver abscesses, or also we have acute non-suppressive. In the next slide I speak about that. But sometimes maybe lung or other organelles such as brain, skin also can be infected. In detail, for your exam, the pathogenicity is important. This slide and this slide is very important for your exam. Okay. And also about the intestinal amoebiasis, you should know this slide. I told you some of individual histological is asymptomatic, and some of them have symptoms. Symptoms can be variable. In some people, we just have colitis. We have just inflammation of the large intestine. They don't have any dysentery. But in some people, based on the pathogenic factor, all of these based on the pathogenic factor. In some people, we have dysentery. Here, histological attached to the intestinal tract. They invade to submucosa, to a deeper layer. And produce the lesion or ulcer. The ulcer is flask shape. They attach to the small intestine and invade and produce the flask shape ulcer in the large intestine. This is the epithelial cell of the large intestine. Histological attach, invade, and they multiply. They produce, I told you, they produce toxin. They can digest our epithelial cell. They can phagocyte. This is the muscle. This is the muscle out of the. This is the, if you see the lumen. This is the lumen. This is the layer of the large intestine. Okay. They can attach and produce these flask shape ulcer. This is the large intestine. They produce these lesions. They are very tiny, but if we section pathology cross-sectional section. They are epithelial cell, and this is the ulcer, this is the flash-shaped ulcer, this is the typical, if the pathologist see this in the section of the epithelial cell, definitely this is one of the hallmark of the histological. And also, in the chronic form, they produce amoeboma. Gradually, in the chronic, this is acute, in acute stage, and in this people, they have dysentery and the hematophage, RBC, we can see all of them in the dysentery or stool of the patient. But sometimes when they gradually in the lumen, they multiply and gradually they produce some granulation because of the acute inflammation. Do you hear about polyp in the colonoscopy? Sometimes we have some granulation. This is histolytica in the tissue, okay, in the amoebiasis. You see, and this is the RBC that they phagocyte. They can phagocyte all of our epithelial, all tissue. They can phagocyte, not just RBC. This is granulation. This is granulation in the histolytica. In the chronic stage, when, for example, the physician can't diagnose, unfortunately, gradually, histolytica stimulates our immune system, and because of the immune response, the normal tissue produces some granulation, and we say amoeboma. In the colonoscopy, the surgeons cut it. Okay, this is like polyp. Okay, they cut this polyp and send it to the pathologist, and they see this amoeba and so many inflammation cells in the pathology section. So in the chronic stage, they can produce some granulation in the lumen attached to the intestinal tract, but it is like a polyp inside. The surgeons can macroscopy, they can see that in the colonoscopy. Also, they can produce appendicitis. Appendix is this is appendix. So appendix is a part of large intestine. Histolytica also not only can infect the large intestine, they can also go through the appendix and invade to the epithelial cell, produce inflammation, and here we say appendicitis. You know that ITIS at the end of that is inflammation. So you should know that this is this slide is important for your exam, intestinal amoebiasis. And in severe form, just I want you to memorize different, for example, stricture, intussusception, sometimes bleeding may be happen, but the most important things is peritonitis. Sometimes histolytica. Here is the
lumen.
This is lumen.
Yeah.
This is the space inside the colon is lumen. This is the we say
Wall, yeah.
say wall, yes. This is the epithelial cell, this is mucosa, this is submucosa, and after that we have muscle. This is outside of the lumen, we have the muscle, soft muscle that outside of the lumen, outside of the large intestinal wall, we have the muscle. It is very hard for histological that to digest these, but sometimes histological can also digest these muscle and go to the cavity of the abdominal. Here we have peritoneum. Okay, we have the peritoneum, and the peritoneum coverage our abdominal cavity. And here we have so many immune cells, and it is a stream without any bacteria, without any microbial agents that penetrate to the cavity, penetrate to the peritoneum that produce acute inflammation. That it is very dangerous and can be fatal. So sometimes histological can digest the muscle around the intestinal tract and go to peritoneum, produce the acute inflammation, which is very dangerous. And the most important things in the histological that can be lethal is peritonitis. So we should diagnose the patient as soon as possible, because when we diagnose late or sometimes misdiagnose, sometimes, for example, we misdiagnose with IBD, with Crohn, because in IBD or sometimes, for example, in Shigella, other microbial agents, also we have RBC in the dysentery. We should diagnose and differentiate all of these diseases from each other. If we misdiagnose, use the wrong drug. For example, use Proton. Maybe gradually we have ameboma, sometimes we have peritonitis. Also here we have some mesenteric vessel. Yes, histological can invade this vessel, and because of that, the patient maybe have bleeding. The other option that we should memorize, so you should memorize bleeding, peritonitis, and also colitis after dysentery. In colitis after dysentery, sometimes we recognize, we diagnose the patient, we treat the patient, but after using the drug, also we should know that the patient have colitis because the histological invades in deeper layer. It takes time that the body repair these lesions, and also we have so many antigen here, and because of these antigen, immune system produce antibody, so we have the attack here, and because of the reaction of the immune system to these antigen, we have immune response. So we have the symptoms that we say colitis after dysentery. But the most important thing is extraintestinal. In some people, histological penetrate to the vessel and go to bloodstream and go to, for example, liver, lung, and other organs, and produce extraintestinal amebiasis. All of this depends on the pathogenic factor. In extraintestinal amebiasis, mostly happen in liver, because why it have just mostly happen in liver? Because the bloodstream first go to liver. So accidentally, every bacterial agent that spread from the large intestinal tract first go to liver. So this is more the infection of the liver is more common than other organs. But in the liver, what's happened? In the liver, two things maybe happen. In some people, histolytica come to our liver. This is liver. Histolytica go to liver. The immune system, this is histolytica. The immune system can phagocyte that, can invade that, and can vanish the amoeba, because the liver system, our organ, all of them are sterile, and we have so many immune system in all of the organ, like liver. In some people, the immune system degrades the amoeba, but so many antigen, so many toxin, because of the degrade of the amoeba, so many toxin and antigen released in the liver. So the immune system responds to these toxin and to these antigen, and because of that, the inflammation, the acute inflammation happen in the liver. Liver is enlarged, bigger than normal. It is very painful, and we said amoebic hepatitis. So it is like hepatitis, like viral hepatitis. The liver is bigger than normal, and this is because of the reaction of the immune system to these toxin and antigen. In the second choice that mostly happen, our immune system can't degrade the amoeba, and the amoeba can attach to the hepatocytes in the liver, and they gradually produce the abscesses. They produce abscesses in the liver. Mostly this happens. The immune system, amoeba go to liver, and immune system can't degrade, can't kill the protozoa, and the protozoa attach to the hepatocyte. They multiply, they digest our hepatocyte, they digest the immune cell. For example, we have some mucus and produce some abscesses that we say liver abscesses. It is very important. We say amoebic liver abscesses, ALA. If you search or Google it, amoebic liver abscesses, ALA. So the most hallmark of extraintestinal amoebiasis in histolytica is amoebic liver abscesses. This is the liver abscesses because of the multiply, because of replication, and this is also the abscess. In the CT scan, there are sometimes if the patient, if the liver abscess is very large, here is it is very big, and because of that we can see the lung here. And this is the CT scan of the patient. This is liver abscesses. So in the diagnosis, the paraclinic in extraintestinal is very important. A patient with the pain around the liver come to you, you should ask for the radiologic or CT scan, sonography, and after that you see something in some abscesses in the liver. You should distinguish it with viral abscesses, bacterial abscesses, or sometimes cancer. And we have we have a chart. If you, I think after you go to the hospital for your course, based on the, for example, shape of the abscess, you have a different chart, and you should go and rule out the microbial agent. So because for each of the abscesses, you should go for a specific diagnostic tool. So it is very important for you that you should know all of them and rule out and diagnose rapidly and correctly, of course. Previously, because sometimes the abscesses is very big, these abscesses can gradually bigger, sometimes they are smaller and they hold together and produce bigger abscesses. When the abscess is very big, they puncture these abscesses, and sometimes they send it to the laboratory. But this is very dangerous because the amoeba, when they put this syringe, the amoeba can attach to the skin and produce granulation in the skin. Most of the times, it is not the diagnostic tools. In the next slide, I told you how we can diagnose the liver abscesses. But sometimes when the abscesses is very big, they function of the abscesses to prevent the rupture of the abscess. If the amoeba, if the abscesses rupture and amoeba penetrate to the peritoneum, they can produce peritonitis. So how we can diagnose this disease? In intestinal amoebiasis, the most important thing is a stool exam, because amoeba is in large intestine, and these amoeba spread to the stool. So with the stool exam, SE, okay, a stool exam, we can see these amoeba and RBC in the small in the stool of the patient, and we can recognize that. I don't want you to memorize all of this, just you should know that the gold standard for diagnosis of the laboratory, for diagnosis of intestinal amoebiasis is a stool exam. We can use fresh lumps, we can use concentration methods, permanent staining. I don't want you to memorize that, just know about the stool exam. Also, I should write it, I should edit it for you. Also, we can use the serological test. We can check the antibody in the serum. Do you know serology?
PCR.
CT scan is important.
What?
CT scan to diagnose.
No, this is intestinal amoebiasis.
Yeah.
In
So
intestinal amoebiasis, we don't use CT scan. In intestinal amoebiasis, maybe we use colonoscopy. But for example, the patient come to you, have, for example, they said that I have, for example, diarrhea.
yeah.
If they are come from the endemic region, you should ask the laboratory for a stool exam, and in the stool exam, they can recognize these amoeba and report for you. You should know that about the stool exam, you should do a stool exam 3 times. Okay? Because they temporarily spread to the stool. Sometimes for example, in just one specimen, we can't recognize. So it's much more better that the patient have 3 samples of the stool. They send 3 samples of the stool to the laboratory. So with a very simple method, like the stool exam, we can recognize. Also, histological, because they invade deeply, we have the good titration of the antibody. So with serological tests, we can check the antibody and diagnose the histological. A specific antibody against the histological. In the stool exam, we have RBC, this is hematophage. This is the direct exam. We don't use permanent staining. In permanent staining, in the first slide, you see, this is this is hematophage. These are RBC. We stain it with the permanent staining. So it is very simple. But in the routine laboratory, they don't stain the stool. Because of that, the diagnosis of histological is very difficult. Sometimes it misdiagnosed with white VC. So it is important that it's better to send the stool to the referral laboratory or the laboratory that you know that they are high qualified, because the most important things is misdiagnosis. Unfortunately, sometimes because it's very hard, sometimes they misdiagnose hematophage with white VC, or sometimes the patient have Shigell's bacterial dysentery, not histological. In Shigell's or bacterial dysentery, we have so many white VC. Unfortunately, some technicians in the laboratory misdiagnose white VC with hematophage, with histological, and report histological. But it was not histological, it is Shigell's, and the treatment is totally different. Unfortunately, or sometimes they have, for example, cancer, have dysentery, they have IBD, have dysentery. Nowadays, because the number of histological is lower than previous last decades, it's gradually decreasing. We have the problem of misdiagnosed or false positive. We have false positive results. For example, other disease with dysentery, because they have white VC, they report it as histological, and because of that, we miss the treatment. Most of the times the patient in gastrointestinal tract, the diagnosis is very difficult because different criteria can affect on the symptoms. And besides that, when the laboratory or the physician diagnose have a wrong diagnosis, it's very, it has a side effect for the patient. So the laboratory and the physician is very important. They should diagnose it rapidly and correctly. And also we have cis-passer. In the cis-passer, in the carrier, we have the histological, but here, because we don't have any symptoms, we don't have any hematophage, we don't have any RBC, they has the cis form, mostly the cis with 4 nucleus, and here, because the shape of the cis of histological is simple, it's very similar to entomopathy this far. We, in the World Health Organization or WHO or CDC, they recommend that we should report histolytica cyst as entomopathy histolytica / hispar. We must report histolytica cyst / hispar because they are the same. We can't recognize based on the morphology. We can't recognize histolytica and hispar. We also have some molecular methods, biochemistry method, we can distinguish them. We have so many kits that can distinguish. But under the microscope, we have to write histolytica / hispar. But most of the physicians, if in the report the laboratory writes histolytica / hispar, they treat because they are reservoir of the disease, they are cis-passer. If it is histolytica, it is pathogen, this person can infect other, so we should treat that. About the extraintestinal amoebiasis, in extraintestinal amoebiasis, histolytica come to the liver, produce, for example, liver abscesses. The gold standard for the extraintestinal amoebiasis also is detection of the antibody against entomopathy histolytica. So the gold standard is antibody detection or serological test, such as IFA ELISA. So memorize the serological test. Because histolytica is in extraintestinal, we should use paraclinical test, CT scan, sonography, and after that, if you suspect for histolytica, you should ask for antibody detection for histolytica. Because we can't preparing the specimen, for example, from the liver, lung, or extraintestinal is invasive. Okay? So when we don't access to the specimens, like extraorganal, the better choice is antibody detection. With the, for example, prepare the blood, preparing the specimen is very simple. With the kit, serological kit, we can detect the antibody. When you ask the laboratory the test, you should pay attention to the price of the, for example, the test. It is available or not in your endemic or in the place that you're working. Is it available? How much does it cost? And the patient can have the money for that, because most of the times some infectious disease in the region that they are developing country, and also the best choice, you should know that for each disease which of the tests is gold standard. About the treatment, we have different treatment for intestinal and extraintestinal. Some of them, for example, metronidazole, and some of them is for both of them. For example, in asymptomatic or in cis-passer or in the symptomatic also, we have different treatment, deoxynitride chloride and iodoquinone, metronidazole. You see chloroquine. Chloroquine is the drug for malaria, but also we use it for colitis. And also for extraintestinal, we use metronidazole or chloroquine, and different drug can be used. But between all of these drugs, I want you just to memorize that. About the azole, metronidazole. This azole, metronidazole, we can use it both extraintestinal and intestinal amoebiasis. It can cover both of these, stage, and most physicians prefer to use the drugs than that coverage all of the stage of the disease. Okay. About yes, about the other parasites, we have Entomobacter coli. It is non-pathogen. Just for your practical, I give you the slides for your practical because tomorrow I am not at your class. Dr. Salimi goes to your class. Please check out the slides of your practical class before the class. For tomorrow, in your practical, you see histological, the cyst-form with 4 nucleus. You see that? The hematophage, the histological with RBC, and if you see the background, you see also RBC because it is from the dysentery. The patient also have dysentery. Also, you see Entomobacter coli, the trophocytes, and the cyst-form. The coli, you don't see any RBC because it is non-pathogen. You see the karyosome, it is acentric, it is not in the middle, and also the peripheral chromatin is irregular. Some places colorful and some places is tiny. But in histological, it is fine and regular. And also in the coli, this mature cyst has 8 nucleus. You see the 8 nucleus, but in histological you see 4 nucleus. Tomorrow you go through about your morphology. I don't ask any question. So about the symptoms, the diagnosis, the treatment. For example, treatment, just memorize about the metronidazole. Check it for, you should know that, but because your exam is very hard, I know that. I just want you for memorize just about the metronidazole, okay? Okay, go for the break.